Hello, I'm Jan Leifman.
And I am Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Alok A. Dr. Khorana is the Sondra and Stephen Harris Endowed Chair in Oncology Research, the Vice Chair of the Taussig Cancer Institute, Director of the GI Malignancies Program at the Cleveland Clinic Lerner School of Medicine of Case Western Reserve University.
In today's presentation, Dr. Khorana discusses the microbiomic interplay in young onset of colorectal cancers.
Did you know that Dr. Khorana is the author of the Khorana Risk Score for venous thromboembolism in cancer patients?
A true inspiration in the field of medicine.
So let's tune in and learn from this global leader.
Another way we can get insights into understanding young onset colorectal cancer is from understanding the microbiome. So as I'm sure all of you know by now, microbiome is exceedingly important for diagnosis of the cancer, for understanding the prognosis, factors placing it into remission, and potentially in the future for choosing therapy or other interventions. And the microbiome is affected by many different things. Diet obviously is a factor that affects microbiomes. In cancer patients, the type of chemotherapy that we use, immune checkpoint inhibitors can affect the microbiome. Medications administered during treatment, including antibiotics, may affect the microbiome. And when we say microbiome, we actually mean two different microbiomes. We mean the tumor microbiome, so the microorganisms present within tumor cells themselves. And then we mean the fecal microbiome or the gut microbiome, which may have an impact on prognosis and response to treatment as well. We've seen already sort of these different early life exposures, and one theory is that many of these, the so-called exposome, so the different things that you're exposed to in the prenatal, natal, postnatal, early childhood, adolescence, young adulthood phase, may in fact act by the development of the microbiome. And some factors, some elements in the exposome, such as the global westernization of diet, unhealthy cooking practices, greater consumption of red and processed meats, synthetic dyes, and so on, may alter the microbiome towards greater immunity and inflammation, which would lead to more cancer, may lead to obesity, which can predispose to cancer, may lead to diabetes, which can also predispose to cancer in adulthood. And so the theory is that at different portions of the process, from normal colonic mucosa to initiation of DNA damage, to promotion and proliferation of cells, and to progression, different bacteria may, or microorganisms may impact pathogenesis differently. And that's kind of hypothesized on here based on some data that's becoming available. And so this whole concept that that we move from a homeostatic system, as shown on the left, to sort of maladaptive behavior, which leads to barrier dysfunction, which can lead to inflammation, which can lead to hyperplasia, and eventually to tumor, driven again by different microorganisms at different phases during this process, which lead to a different interaction with the immune system, which in turn either helps or hinders the immune process. This understanding is starting to gather momentum. And in fact, we see that if we study microbiomic profiles in colorectal cancer, some types of microorganisms are increased. Those are listed on the left and commonly include B. fragilis, E. coli, and E. faecalis. And some are decreased, and they commonly include lactobacillus, Clostridium, and a couple other ones. And these different stages can influence these specific bacteria and their products. So to understand this better, we conducted a tumor microbiome analysis of young onset colorectal cancers versus average onset. Here we define young onset as the same as before, age less than 50. We define average onset, trying to get some separation between the two categories, as older than age 60. And these data were presented by one of our fellows here, Shimoli Barod, just a couple of months ago at ASCO GI. We actually had a very large sample size of about 300 plus patients with different stages of colorectal cancer. We excluded some cases because they were either non-malignant or did not have adenocarcinoma, or they were from metastases. So we wanted only the primary. And we took fresh frozen tissue from the primary tumor. We also took paired adjacent non-malignant tissue as control. And so we had a within, in each person, we had a within person control, which was not cancerous. We isolated 16S rDNA and sequence trees were assigned to sort of genus level, and sequence variants were analyzed for alpha and beta diversity. And I'll show you that in a second. And then we did a bunch of corrections and correlation analysis. So here's the characteristics of the patients. Young onset and average onset do differ clinically. And you see, as has been shown in many other studies, that young onset is more likely to be a left-sided tumor, so more rectal cancer, more likely to present with advanced stage, so more stage 4 disease. And because they're more likely to have rectal cancer, they're also more likely to receive neoadjuvant treatment. And certainly all of these things could potentially impact on the microbiomic analysis. On the other hand, this is how young onset patients present. They are different in clinical presentation as compared to usual onset colorectal cancer. So you can't artificially sort of compensate for that. I think you have to accept that. What we found was that if you look at patients above 50 versus above 60, versus under 50, alpha diversity was clearly different, as you can see in the graph on the left. Alpha diversity is the diversity of microbial species within the tumor. And then beta diversity was also different. This is differences in microbial diversity between patients. So one is within patients, one is between patients. And you can see both of these exhibited quite different diversity profiles, suggesting that microbiomic profiles in younger patients were somewhat different. And when we went to the taxa level, we found the relative abundance units of different taxa were different. And you can see this in the profiles here, under 50 on the left, above 60 on the right. And without going through sort of each genus here, I want to point out a couple. Akkermansia was much more prevalent in young onset disease compared to average onset. Bacillus was less prevalent in young onset. And then E. coli and Shigella were also less common in young onset compared to adult onset. Pseudomonas was somewhat greater in young onset versus average onset. But the big news was Akkermansia had probably the highest difference in terms of significance between young onset and average onset. We've also done a network analysis, the results of which you can see here. This sort of provides you with some correlation between the different bacteria or microorganisms, I should say. Patients under age 50 on the left, above age 60 on the right. And the different colored sort of bacteria are shown differently. And you can see these patterns in terms of network analysis are also different for younger versus older patients. So sort of summarize the microbiomic profiling of young onset versus average onset colorectal cancer. When controlling for normal tissue microbiome, we still saw a significant variation in the intratumor microbiome between young versus average onset patients. The presence of Akkermansia, which is generally considered a healthy gut organism, was correlated with improved overall survival in young onset patients and was more prevalent in young onset patients compared to average onset. And as has been shown previously, young onset patients had more left-sided tumors, low-grade tumors, and advanced stage tumors at presentation, and were more significantly likely to receive neoadjuvant therapy as compared to average onset disease. What do the implications of this type of microbiome have on, in terms of interventions? Well, if we better understand microbiomes of patients who are less likely to get cancer, or who, even if they get cancer, are likely to do better, it gives us an understanding of the disease state. It gives us an understanding of the disease state when it is active and when it is in remission. It also can provide us with biomarkers. So if we see certain microbiomic profiles change, and that's predictive of getting cancer, then that would in the future potentially provide us with clues as to which patients to intervene in or which patients to screen. And potentially we could intervene. We could say, hey, here, take these specific microbiomes, and this would reduce your risk of colorectal cancer. I think that's sort of the possibility as we move forward, or go to sort of a polymicrobial type of approach that, generally speaking, if you have more alpha diversity, then you would have less chance of getting colorectal cancer. So these are, diet-assisted microbiome engineering approaches that are currently being considered, and I don't think they're as far off in the future as we might think. We can also track temporal trends in human host using the gut microbiome and diet. As you see, the diet trends have changed recently with plant-based diets and plant source diversity going up and meat-based diets and processed diets going down. And what does that do to the microbiome? That's also a sort of diet-assisted microbiome engineering, right? You're changing the microbiome of the gut based on the change in the diet. And what does that do as we improve our preferences for plant sources and reduce our preference for animal sources? And I think that's going to be interesting to observe over time. And finally, this doesn't stand in isolation. I don't think microbiomics can be used without taking into account various laboratory tests that are surrogates for inflammation, for genetics, for exercise, for age, gender, diet, and all of these could be put potentially into a prediction engine that would be helpful for diagnosis, for prognosis, and for stratification in terms of treatment.